Good evening and welcome to tonight's CPD webinar, Investigating the Breathless Patient, a Practical Approach. I'm Dr Anita Munoz, a GP and medical educator, and I'm delighted to be your moderator this evening. On behalf of PraxHub, thank you for joining us from across Australia. I'd also like to acknowledge that this education has been sponsored by 4D Medical, and we're grateful for their support of this important subject area. We've all had those patients with persistent breathlessness that's tricky to pin down. It could be cardiac, respiratory, anemia, deconditioning, anxiety, or often a combination of all. Many of us have found ourselves ordering test after test, feeling like we're going in circles while our patients wait for answers. This is the first of 2 webinars in this series, and I'm joined tonight by a respiratory physician, Dr. Paul Hamor, and radiologist Dr. Dean Rabinowitz. Our speakers will share a practical framework for assessing chronic breathlessness across multiple systems. They'll guide you through structured history taking and examination that points towards the right first-line investigations, which tests to order early on, including imaging, and what they can and can't tell you. You'll learn what comprehensive lung function testing adds beyond basic spirometry, and how to determine when your patients need respiratory review, cardiology input, or a multidisciplinary approach. Let's get started.
Thanks, Anita, and thanks for having me and inviting me to speak tonight. It's actually a topic I'm pretty excited to present. Dyspnea is such a common presentation, particularly in general practice, but also to respiratory physicians. And I think very often people get tied in or focused on one diagnosis or get fixated on something without thinking through all the possibilities that could cause breathlessness. And I suppose part of the point of tonight is to give you a framework to think about dyspnea and how you can get out of the trap of being fixed on one diagnosis or the other by trying to think a bit more broadly. So when patients come to see me with dyspnea, I like to think of a whole body concept of breathlessness and then work through each one to try and figure out where and why they might be breathless. And I'm going to share that with you now and talk through some of those changes. Essentially, I think about how an oxygen molecule travels from out in the environment down to the leg or the muscle, wherever it's needed to do work. And any step along that way that impairs that delivery of oxygen is going to contribute to breathlessness. One of the things which I've learned over a number of years of doing respiratory medicine is that it's never one thing that typically causes breathlessness. It's usually multiple things all contributing to someone's breathlessness. So if we think about an oxygen molecule in the air here, first we need to breathe that in and out. We breathe the oxygen in, we breathe carbon dioxide out. And so when we are doing spirometry, that is what we're measuring. Any impairments with airflow in and out. The next step is diffusion. We've got to get that oxygen molecule across that alveolus capillary membrane to be absorbed into the blood. And so if there's impairment there, either with pulmonary fibrosis or pulmonary edema or emphysema, that will impair that process. And that's only really tested with lung function testing with something like gas exchange, DLCO, KCO, which are done in respiratory laboratories. The third is once it's in the blood, it needs to be absorbed by a red blood cell into hemoglobin. And so if someone has low blood counts, they're anemic, or they're iron deficient, they'll have impairments. Or if they have a hemoglobinopathy as well, they'll have impairments in that ability to absorb the oxygen into the red blood cell. The next step is that little red blood cell needs to be pumped around the body from the lungs all the way to anywhere that needs oxygen. And that's done by the heart. And so it'll come from the lungs into the left heart, and the left heart has to then pump that around the body. So any impairments in cardiac function, whether that be left heart disease, both heart failure with preserved or reduced ejection fraction will impair the ability of oxygen to be delivered and contribute to breathlessness. I suppose the other thing we should note is that in the system between the heart and the lungs, most humans are cardiac limited in terms of their exercise capacity. That is, in terms of the system, the thing that holds us up exercising harder is our heart. The lungs, we actually have a lot of excess capacity to do more effort and work and blood flow. So it's very rarely in a normal person, the lungs which are holding up the delivery of oxygen to the periphery. It's actually how much blood the heart can pump that gets the blood out to the periphery that determines how breathless someone might be in a normal patient. Contrast that just by, as an aside, with horses. Horses are actually respiratory limited. Their hearts are huge. And so, unfortunately, at the end of horse races, horses cough up blood because they're respiratory limited. Anyway, I digress. So after the heart pumps blood around the body, it needs that blood needs to go through all the vasculature, and assuming the vasculature is normal, it needs to then be absorbed by the muscle and utilized appropriately. And so if a muscle is well trained and is large, it can absorb that oxygen well and freely and use it appropriately to do work, whether that's climbing some stairs or running a marathon. All of those require the delivery of oxygen to that muscle to be used. As you know from biochemistry days, we have both an aerobic and an anaerobic pathway in the utilization of in the formation of energy. And so in aerobic respiration, that oxygen will be combined with glucose to give out carbon dioxide and water and energy. But when there is not enough oxygen around and we're asking the muscle to do more effort than the oxygen supplied can be supplied, then the muscle will start using anaerobic respiration, and that doesn't use any glucose and produces lactic acid instead. And that lactic acid needs to be gotten rid of in some way, and because none of us like our blood to be acidic, and the way we do that is to blow it off. That's the quickest way to get rid of acid in the blood. So that causes breathlessness. So when I think about breathlessness, we need to look at the pathway of oxygen all the way from the top in the atmosphere, all the way down to the muscle tissue, and then try to figure out which of those may be impaired. In addition, the biggest contributor to breathlessness is how we perceive breathlessness. And so there is a supratentorial component. There are some people who, for whatever reason, don't feel any breathlessness, even in significant stressful situations. You've probably seen those videos of free divers and things like that. There were studies and experiments on humans done in the 80s and 90s where they would put on a sealed mask and measure people's respiratory rate as a proxy for how breathless they were, and then slowly turn down the oxygen or slowly turn up the carbon dioxide to see how people responded to those insults. And there was a huge variation from human to human on our responses to hypoxia, to hypercapnia, but also just to the general thought of having something on your face and the feeling of getting breath. So there is a cerebral component to breathlessness as well. And it's a bidirectional relationship. So anxiety can cause breathlessness, but breathlessness, if you can't breathe, you'll be pretty anxious. So I think it's important to keep all that in mind when we're thinking about a patient who presents to us in the first step with dyspnea. It also explains why it's very easy to get focused on, in general practice, but it also happens in the specialties as well, why we can get focused on one particular cause of breathlessness and kind of forget about the others. And so hopefully this framework will prevent that anchoring that may occur from time to time. But it also explains why some multimorbid patients who have multiple things going on, they've got a little bit of heart disease, they've got a little bit of lung disease, they're overweight, they're sarcopenic, so they've got low muscle bulk. Why fixing one thing, like their heart or giving them a puffer, doesn't truly fix their breathlessness, because there's other things going on as well. And I suppose the model which I just presented gives us a guide on how to think about our investigations and how we prioritize and strategize those and interpret them within that larger setting of the patient's symptoms. So I want to go through a few definitions and use sort of, when I went through medical school, I used Murtaugh method, and I think it still stays so clear in my head as to how I think about differentials. So you want to think about the timing of someone's breathlessness. Is it acute, subacute, or chronic? Acute breathlessness has come on very quickly, and it can be super acute. So something that happens in a few seconds might represent a myocardial infarction or a pulmonary embolism. But the aim of this talk really isn't focused in on emergency medicine type of breathlessness. It's these patients who you're really struggling with, that they've had breathlessness, chronic breathlessness, and chronic means they've had it for more than 3 months. They've had breathlessness that has persisted for over 3 months, and despite your interventions and despite your investigations and history and management, they're still breathless. And so that's what I really want to focus on today. One of the things you can ask the patient is, what seems to worsen your breathlessness? Is it only on exertion? Is there a positional component to it? Does it seem to be paroxysmal? It just comes out of the blue from time to time. All of those might give clues as to what system you might be looking at. You also want to really exclude red flags that might portend something more serious, like chest pain, hemoptysis, orthopnea, or if it's rapidly progressing over a few weeks. The post-viral syndromes have been talked about a lot recently, particularly in the light of long COVID and similar things. For respiratory physicians, we've been dealing with a post-respiratory virus syndrome for a number of years, and the fact that people got long COVID from another respiratory virus wasn't a huge surprise to us. I suppose what was surprising was how many people it affected, but I suppose that was a reflective of how prevalent COVID was a few years ago. But that post-COVID syndrome, or those post-viral syndromes, are also very multifactorial. But those patients also had a lot of other risk factors for quite serious respiratory disease. The COVID could have caused pulmonary fibrotic change. I saw a lot of post-COVID asthma, or asthma that was flared up after they got COVID. We saw patients who developed pulmonary embolism from COVID. We saw patients who developed significant cardiac disease or pulmonary hypertension, again, from their COVID. And even people who survived their COVID, if they're very unwell, developed a degree of deconditioning and weakness because of their severe illness. So when someone presented to me or to a long COVID clinic with breathlessness, these were the sorts of things we were thinking through as well. One of the things which I use to try assess patients better is to get a better understanding of how it's affecting them. Are they limited by their breathlessness, or does it just bug them? Because once you start noticing breathlessness, you notice it everywhere. You'll notice it walking up the stairs, or, walking around a park, or playing with your kids. And that may or may not be abnormal. But if it stops you from doing what you want to do, then I think that's probably more serious. It's quite normal for someone to walk up a flight of stairs, or 2 flights of stairs, and have to breathe harder, deeper, faster, because we are delivering more oxygen from out in the world to that muscle in the leg, which is doing work. And in fact, if you didn't breathe harder, deeper, faster, there'd probably be something a little bit wrong with you, because all of us need that oxygen to do the work that we're demanding of that muscle. And so I have a lot of patients who will come to see me and say, I'm breathless walking upstairs. And I need to dig a little further. So when you walk up the stairs, do you need to stop? And if you do stop, how long does it take you to recover when that happens? Or I have a lot of people around here, and this was common during COVID, who were walking with friends, and they would walk a set distance, week to week. And so they have kind of a baseline that they can calibrate against. And then, so I asked them, compared to your friends, have they noticed a change in your walking, or are you having to walk slower? Which might give a clue that there's something a bit more going on than just a normal variant of breathlessness, or physiological breathlessness. So there's some other clues that you might be able to trigger in your history. Then obviously to your exam. So this is pretty basic sort of things, but you do need to take a multi-system exam when trying to understand breathlessness. So auscultating the chest, making sure that there's no crackles or wheeze or signs of hyperinflation. You do have to remember that the lungs, if you only listen to the front, you're only listening to the upper lobes, and the lower lobes come up to about this level. So if you listen up here, that is still upper lobe. And from this level down, it's going to be lower lobe. And so if someone has quite focal pulmonary fibrosis, or if they have upper lobe pulmonary fibrosis versus lower lobe pulmonary fibrosis, if you're only listening to one spot, you're going to miss it. Similarly, if you listen up the top, you're going to miss basal crackles due to pulmonary edema or something like that. So it is important to listen front and back, top and bottom. I teach my medical students that when you listen with a stethoscope, you're really only able to auscultate about 1 centimeter circumferentially around the base of the diaphragm that you're listening to. So if you have a stethoscope here, it's about this distance wide, about this distance deep that you're listening to, unless they're transmitted sounds like wheeze, which can move a little bit further. But most crackles, you'll only hear in that focal section. And so it's important that you do listen broadly and widely in the lungs to auscultate adequately. When looking at the cardiovascular system, you want to look at the JVP and signs of fluid overload, peripheral edema, listen for any murmurs, particularly new murmurs that might not have been documented by previous clinicians. You want to be looking for signs of anemia. Neuromuscular disease is commonly missed in the presentation of breathlessness, and it will present as weakness in some areas. It could be peripheral muscle weakness. It could be generalized weakness. You might see fasciculations that might suggest someone has neuromuscular disease or MND. They might be having falls or tripping over themselves. So they're more serious neuromuscular disorders, which will probably, and most of them are progressive, and if you don't pick them up initially, the patient will probably present with them with more significant symptoms later and more significant signs. But one of the things which I think is often forgotten with neuromuscular is the more simple things like kyphosis or scoliosis, or leg length discrepancy if people have had hip surgeries or if they've had a hip fracture. So if someone is walking lean to on one side and has a circumferential, circumductal gait, I can't remember the exact name, but where the leg goes out and around, they're going to have to use a lot more work and effort just to walk the same distance as someone who has a normal gait and a normal bipedal stride. So that also contributes to the people's perception of breathlessness. And physiotherapy and strengthening exercises can help reverse some of those changes. One thing which I think is also particularly useful is just a simple walk test. I get them out to my corridor and get them to walk down the end of the corridor and back. And I'm in a building that's a few stories high, and I'll get them to walk up a few floors with an oximeter on their finger. And if their oxygen levels drop, that is very abnormal and probably requires a referral to a respiratory physician with a phone call so that it's not left too late, because a person's oxygen should never drop with simple exercise. It only happens in disease and very rarely happens in super elite athletes. but that's it. No one in between should be having oxygen saturation drops. And so all these gimmicks of the smartwatches, like the Apple Watches and the Samsung watches that measure your oxygen levels, I don't think they're particularly helpful because they're not that accurate. And if the saturations do drop below 92%, that's a big flag that the watches should be telling them to go see a doctor almost immediately. So I think that's really important to be aware of. And so after you've done your history and you've conducted a thorough examination, think about first-line investigations that you can do in primary care. And one of the things which I appreciate is difficult in most GP practices at the moment is in-room spirometry. A lot of spirometry was stopped during COVID because of the risk of viral transmission at that time. And it does take time to do properly and is very poorly remunerated in the GP community. And I think it's terrible that it's as poorly remunerated as it is. It takes a long time or a lot of training to do good spirometry. And if done properly, should take the operator about 10 minutes if you're doing pre and post, as is required for MBS. But what I'd suggest is if you do have an old spirometer lying around and you're not worried that they have an acute respiratory infection, do a 1 or a 2 blow spirometer. Just get them to do a big breath and blow into the spirometer. If it's normal, that's hugely reassuring, at least from an airflow in and out perspective. If it's abnormal, I think you've got to take it with a grain of salt because the technique and effort is so important in in getting proper results from spirometry that you want to take that with a bit of caution. But if it's normal, I think that does provide some reassurance to both you and the patient. So I often get referrals from GPs that say, our spirometry shows there's restriction, please review. And we do our spirometry in rooms here and it's normal. And we call that pseudo-restriction. And essentially, it's just because the patient has had a very poor effort. They take a big breath in and they go, huh, and the volumes are small and the curve looks short and sharp. So it looks like a restricted pattern. But unless you've actually seen the patient do the effort yourself, which in a lot of GP practices, it's the nurse who's doing it, I think it's difficult to interpret that, or I wouldn't overinterpret that response. The things which aren't available on GP in-office spirometry, which we do in a more dedicated respiratory lab, would be formal spirometry, inspiratory and expiratory done by a respiratory scientist. That's number one. We'd also be doing gas exchange capacity with DLCO maneuvers, looking at the diffusing capacity of carbon monoxide, which will look at that second step of oxygen moving across into the blood itself. And then we also measure lung volumes in a body box. And we may do, depending on the lab and also the clinical picture, we can also do respiratory muscle testing to see whether someone's respiratory volumes drop when they lie flat, or do maximum inspiratory pressure and expiratory pressure testing, which might look for neuromuscular disease. So these are the sorts of things that may be available in a respiratory lab that won't be available in your rooms. And so if your spirometry is normal, it doesn't mean that you should skip a full set of lung function testing in a dedicated respiratory lab, because the lab will be able to go on and do further tests such as gas exchange capacity, lung volumes, looking for restriction or gas trapping. And you'll also have the benefit of getting a little bit of insight from the respiratory physician who interprets it. And hopefully they give you a little bit of help back if you give enough information on the referral form. So that's first-line respiratory investigations. Next would be first-line cardiac investigations. So I think it's pretty easy these days to get an echocardiogram. And I think an ECG and an echo are pretty good first steps. But you'd probably need to speak to your cardiologist as to when you might consider stress testing as well, versus doing a screening CTCA. And I think if someone complains of breathlessness, an actual test of exercise is useful, because getting them onto a treadmill and walking them, and the cardiologist observing what happens when that is, really is very useful in helping them to understand whether there's a cardiac cause of breathlessness. What I think cardiologists don't do as well, and not everyone does this, is they might do a stress test, but might not necessarily do a stress echo, which would be more sensitive in picking up changes for breathlessness. And universally, and I don't know why, they never check oximetry when they're doing their stress test. So they'll miss if someone's oxygenation falls with exercise, which might just raise more questions if all the other tests are normal. So there's some things to think about with cardiac investigations. So the next thing which we need to look at is blood tests. So thinking about that next step in the oxygen pathway down, we need to look for anemia and do some iron studies to see whether there's a component of that contributing to breathlessness. But in addition, if you think about back to Murtaugh manual, all of those, I think they were called the common masqueraders or the 7 masqueraders. You've got to think about someone's thyroid. You've got to think about their renal function, other inflammatory markers that might be up, and thinking more about blood tests. Their NT-proBNP is a way of looking for cardiac strain that may have been otherwise missed when the cardiologist is doing their echo. There have been many times in acute breathlessness rather than chronic breathlessness where there's been a renal disorder and someone's got a renal acidosis that's presenting as dyspnea, or someone is septic and has acidemia and a high lactate, and they're breathless because of that as well. And often they'll come into the emergency department and get admitted under respiratory, unfortunately, with a normal chest X-ray or a normal CT scan and not hypoxic, but they're breathless, so they end up under us, and they're septic from somewhere else. It's very common to see in septic patients or patients who have thyroid dysfunction or renal problems. All of this can be done pretty much, except waiting for lung function tests in the lab. Most of the things which I've just been talking about can be done in primary care. And it does make a big difference when you're referring to a specialist if these tests have been done beforehand. I know that in our public clinic, our waiting time for a general breathless patient who's not urgent, who's had breathlessness for a few years or several months, without a clear reason to prioritize them, they'll be waiting up to a year to be seen by a respiratory physician. And I know that that's the case in other public hospitals around this state. I'm in New South Wales, but I definitely know that it's a little bit worse in Victoria and the public clinics as well. So depending on the hospital that you're referring to. So we've gone through most of the investigations that we can do within primary care, but we haven't talked about imaging. And that's the last final puzzle in trying to figure out why someone might be breathless. There are a range of investigations open to you to think about when you're doing thinking about breathlessness. You might want to order a chest X-ray or a CT scan. But if you're ordering a CT scan, what's it going to be? Is it going to be an HRCT or a CTPA or an ultra-low dose CT scan of the chest? There's a whole range of options. And I think it would be easier for us to hear directly from a radiologist about his experiences in receiving referrals from GPs on what he prefers to hear from you and how he thinks about imaging when someone has unexplained breathlessness. So I'd like to introduce Dean Rabinowitz. He's a radiologist who works at Prince Wales Hospital and also at Spectrum Medical Imaging. And Dean, take it away.
Thanks, Paul. As Paul mentioned, I'm a radiologist from Sydney. I work at Spectrum in Prince of Wales, and I do body imaging, which is mainly chest and abdominal. I do quite a bit of oncology as well. And yeah, to answer your question, Paul, there's definitely some key imaging that we need to discuss in terms of shortness of breath. This is an overview of some of the types of imaging that I'm going to be talking about. And I'm going to try and focus on why you would choose to do each of these types of imaging in which clinical setting. And later, when Paul shows some cases, we'll dive into a couple of examples of these. So chest X-ray is the mainstay or the first line investigation. We often use chest X-ray in an acute setting. So particularly if you have a high clinical suspicion of an infection or of a cardiac pathology, it's quite a useful test. But it's not a test that has a high degree of sensitivity, and its accuracy for some pathology is quite low. So it's really there to rule in or rule out major pathology, and it's not to be seen as an end study. So if a chest X-ray, the way I like to explain it to some of my registrars is that if a chest X-ray is normal, it does not mean the patient is normal. There may still be pathology. So this is just a couple of examples of a normal chest X-ray, just demonstrating, what we tend to look for. We might, if we're reporting this, call it a normal chest X-ray, but this is the accompanying CT scan. And on the CT scan, there's clearly an abnormality, this cavitating lesion at the left apex anteriorly, which you cannot see on this chest X-ray. So that important point that a chest X-ray is not, a normal chest X-ray does not rule out pathology. We're doing it in an acute setting to help guide management. But if a patient is short of breath, a normal chest X-ray doesn't mean that there isn't pathology to be found, which then brings us to the next type of test, which you'd be familiar with a CT chest. But the important point here is that a CT chest is not a single type of study. There are many different subtypes of CT that we use in different clinical settings. So CT generally is used in order to assess the anatomy and the structure and patterns of diseases, to look at severity of disease. But a radiologist would choose a different type of protocol depending on the clinical situation. So that is why the clinical information that is provided to us is key to be able to choose that correct protocol to answer that question. So, the more information that can be provided to the radiologist, the easier it becomes for them to choose what type of test. And what I mean by that is that you can do a CT chest as a standard CT with contrast. You can do it without contrast. You can do it with dynamic phases. You can do different reconstructions to look at different parts of the chest, the soft tissues, the lung, the bone. We can employ advanced techniques like spectral imaging. We can do special things like fly-throughs, MIPS. We can do 3D vessel mapping. We can plan for particular clinical scenarios, like, for example, if we're planning for valve replacement in emphysema. All of this really requires us to do quite a bit of planning, and that means understanding what the question is. And importantly, there are emerging techniques that thankfully are making our job a lot easier. And I'm going to touch on one of these, CT LVAS and CT perfusion. So one of the main types of CT protocol that you'd be aware of is the CTPA. So this is a pulmonary angiogram. It's going to cover the chest in the same way that any other CT would, but our focus here is on the pulmonary arteries. So what we are trying to do, so this is just a chest X-ray showing you a major pathology on the chest X-ray. It looks like it could be an area of a consolidation, but because of the clinical scenario, we might decide to do a CTPA to look for a pulmonary embolus. And that's what this is over here. It's a CT pulmonary angiogram. We've got contrast that we are timing to get inside the pulmonary arteries, and the filling defects here are the pulmonary embolus. And really, if we don't know that we're looking for a pulmonary embolus, that timing would be off, and that information would be less likely to be picked up on the study. The other test that's really important protocol to mention is an HRCT chest. Now, unfortunately, the name HRCT chest is misleading. it used to be that people thought this meant high resolution, meant that it was a better test. But most CT chests these days are performed at high resolution. There's no difference in the majority of CT chest in terms of the resolution itself. So these tests should be better named a dynamic CT chest. They're dynamic because they're taking the lungs positioned in different, the patient position in different maneuvers in order to see different aspects of the lung, specifically in inspiration, expiration, and prone. So I'll show a couple of examples of this. This is an example of a supine study, and we can see there's an abnormality at the posterior part of the lung. But when you flip the patient over prone, so when you do a maneuver, all of a sudden that pathology has disappeared. And that's because it's not pathology. It's a transient finding that is completely resolved when you flip the patient over. This can be misleading if you don't do the prone, because we could call this interstitial lung disease, but in fact, it's nothing. It's no pathology at all. Another thing that we do is an expiratory phase. An expiratory phase allows us to identify areas of air trapping. If you don't do the expiratory phase, we can overcall air trapping on a standard CT. So that's why when you think of HRCT chest, think of it as a dynamic test. It's a test that's being done in order to look at the lung in different maneuvers or in different patterns. You can do combinations of these, so you can give contrast and you can do an HRCT chest together, and that's sometimes useful in some clinical scenarios. CT LVAS is an emerging technology. This is something that has been TGA approved. And essentially it's a non-contrast study as part of an HRCT chest. It's exactly the same phases as we would do in a standard HRCT protocol. But what happens is that we upload the data, we do some very specialized post-processing, and in doing that, we're able to identify ventilation within the lung. So not only are we getting visual data about what the structure of the lung is, we're getting functional information about how much air is ventilating in different regions of the lung. And that's really important if we're trying to identify if there is a large or a small scale abnormality in what would otherwise be interpreted as a normal CT chest. So if you're looking at a CT chest and it looks completely normal structurally, that doesn't mean that functionally it's normal. We used to do different types of ventilation tests with nuclear medicine, but this emerging technology has allowed us to put it into the same test that we would normally be reserved for just structural information. The various things that we look at with a CT LVAS include ventilation defects. We also look at the heterogeneity of ventilation. And in the near future, there will be a component which is looking at perfusion. And this will be a game changer because not only will we be able to look at the structure and the function of ventilation, but we will also be able to look at the function of perfusion into the lung. And it's the mismatch of perfusion that is really important for some key diagnoses like COPD, for pulmonary hypertension, and for chronic thromboembolic disease. One other thing I want to quickly mention is that if you're not sure what test to order, you should have a relationship with a radiology practice or with a radiologist, somebody that you can trust, who you can call up and to discuss the clinical scenario. And failing that, there is a really amazing guideline online called the Diagnostic Imaging Pathway. It's a free tool. It gives very clear information about what imaging is useful to do in various clinical scenarios. And this is just an example of chronic shortness of breath using that protocol. You can see it's quite detailed. Each of these yellow sections you can click on and it will give you more detail about the test and where you might be able to, where that test may have some value in a clinical situation. I'll throw you back to Paul.
Thanks, Dean. That was very helpful. I thought it might be useful now to go through a case. And we've got two cases actually to talk about. And both of them go over essentially some of the topics that we've already discussed. So the first case is a 45-year-old lady. You can see her picture there. She looks older than her stated age. And And she's been experiencing 12 months of exertional breathlessness. She really has no other comorbidity. She's otherwise well and healthy, has never had asthma before, is a non-smoker. And the GP did have spirometry in their rooms and it was normal. And the GP has also sent her for an echocardiogram and it was reported as normal. She doesn't have any chest pain. She has no cough. And her symptoms have been gradually progressive to the point that she's avoided exercise now. She's going out less because she feels she gets breathless when she goes out. And so I thought I might go through how I might present this sort of, or how I might think through this kind of case. So for this lady, assuming the spirometry is normal, her airflow and the way the air is moving in and out, if she's got normal spirometry, we can kind of exclude that. We haven't, and I will say this as a caveat, we can never fully exclude asthma unless we do an asthma challenge test, because someone with asthma has normal lung function until it's not. And then they go back to having normal lung function again. So people who have paroxysmal breathlessness, sometimes it's hard for us to fully exclude that just with one-off spirometry. But as a general rule, this lady is having progressive exertional breathlessness. Doesn't feel like asthma, at least at our initial thoughts. The next thing which I would do is doing gas exchange capacity, so looking for the diffusing capacity of carbon monoxide, and getting a full set of lung volumes just to check that we're not missing something else in the lungs. And on this particular test, the DLCO was mildly reduced. I took her for a short walk and walked her up a couple of flights of stairs, and she did desaturate. So she was at 95% at rest, but at the top of the second flight of stairs, her oxygen sats fell to 88%. Very abnormal. And her heart rate did increase quite briskly because of it. She did recover okay. It took her a minute or two, and so it wasn't a prolonged recovery, but there was problems there. The next test, with that in mind, is that if someone desaturates and they've got normal spirometry, so we've excluded COPD or something like that, then the things I'm thinking about, the pulmonary hypertension in particular, or pulmonary vascular disease. And for that, we really need a CTPA to look at it. So they're part of the things that I'd be thinking about. And if you did a plain CT or an ultra low dose CT, it won't be adequate to look at the pulmonary vasculature. So we do the CTPA, it excludes pulmonary emboli, but we still haven't got our answer. So we unfortunately need to go back to the cardiologist who did the echo and say, look, this lady is desaturating on exercise. She may have some pulmonary hypertension that wasn't picked up. And so the cardiologist then did an exercise stress echo and found that there was the development of a tricuspid jet, and she went on to have a right heart cath that did show some pulmonary hypertension, but only with exercise. So you can, when they're doing right heart caths, they can actually get them to exercise within the catheter machine and see the change in vascular resistance with exercise. And so this lady ended up having scleroderma, and her pulmonary hypertension was the first indication of that. And she went on and had treatment for that. But that's just one short case that I think demonstrates how important it is to keep on looking, even when a test is normal. So, for example, the CTPA was normal. We need to keep on looking. And I think the big clue in this case, or the big red flag, was that she desaturated on exercise until someone had actually taken her for a walk and seen that. it could have been missed. And pulmonary hypertension is well known for being difficult to diagnose in early stages. And the delay to diagnosis is often 1 to 2 years from the onset of symptoms to when it's eventually diagnosed. So it's hopefully something we can start to think about and pick up these cases a little bit earlier. Dean, have you got any question or any comments on the use of CTPA in this case, or any other radiology findings that you might want to think about with this case?
Thanks, Paul. Yes, no, I agree with you that, even in a situation where you have a normal study, the fact that that study is normal is still incredibly important for working through the patient's clinical scenario. So if we do a CTPA in the setting and we don't demonstrate any evidence of an acute pulmonary embolus, we might still demonstrate some subtle changes of chronic thromboembolic disease, or we might demonstrate some parenchymal changes, which could explain the patient's presentation. But even if we see none of those on a structural CT, we might be able to elicit some functional changes either through what we traditionally used to do, a VQ scan, or through these emerging technologies like CT LVAS and CT perfusion. So those studies might demonstrate some functional changes that are beyond the scope of what a normal structural study would show. So I've just got on screen an example of this where we've done a CTPA. The CTPA is clear. There's no pulmonary embolus inside the major vessels, which I'm demonstrating. This is the CT LVAS component. And when you look at the CT LVAS component, what we're looking for is these key features of ventilatory defects and ventilation heterogeneity. So even in a normal, as I've mentioned, a structurally normal CT, you might in fact demonstrate abnormalities in your VDP and your ventilation heterogeneity, which could indicate a small scale abnormality. In this case, there was nothing to find. It was still a patient who had no abnormality detected. But that's very important because it then guides us to look for pathology elsewhere, either in terms of, maybe something cardiovascular, or in your case, the fact that she had abnormality on when she was exercising. So another dynamic assessment.
Thanks, Dean. Let's go through some of the key teaching points from that case. I think it's really important to recognize that normal spirometry does not equal normal lungs. And a DLCO, it was low in this case, but just mildly low, can reveal what spirometry can't. I think that it's important to think about what CT modality you choose to answer the question which you want answered. And in this case, it was a CTPA, but in other patients, we might go through a few other cases. In other cases, it might be something like an HRCT, might be more appropriate, or in a young person, an ultra-low dose CT as well. And early testing, for example, in this case, with a whole range of lung function tests, which should be more readily available to GPs than waiting for a respiratory consultation, can mean that the patient is prioritized and seen earlier, leading to less of a diagnostic delay. Okay, let's go on to the second case. So this patient is probably a little bit more familiar in my rooms. So this is a 72-year-old man. He's multi-morbid and he's breathless for heaps of reasons. So he's got obesity, he's got mild diastolic dysfunction or heart failure with preserved ejection fraction. He's got anemia, and he had COVID as well, and he attributes a lot of his symptoms to long COVID as well. He reports daily breathlessness, particularly when climbing stairs or going on long walks. His chest X-ray is normal, perhaps slightly hyperinflated, but essentially normal. And he has basic bloods are normal. His hemoglobin is slightly reduced. Cancer's been ruled out. So thinking about this patient and all his comorbidities, we need to think about how we optimize each one of those comorbidities to better understand and manage his breathlessness. So going through his list, he's slightly anemic. We need to investigate why he's mildly anemic. Perhaps it's just anemia of chronic disease. Or maybe there's something more sinister going on that we need to look at. And that might be contributing to his breathlessness. The next is he's obese. So he's carrying more weight. He's probably deconditioned as part of that. But you don't want to just give the patient a label that they're deconditioned. You want to ensure that that is a diagnosis of exclusion. But his deconditioning is contributing to his breathlessness. So as long as it's safe to do so and his cardiologist says it's okay, some exercise and some weight loss will probably help with his breathlessness as well. The third is his post-COVID symptoms. Now, some of those could be attributed to other conditions. And personally, I don't like attributing anything just to long COVID. I'd like to make sure that I've excluded all of those other things first. Now, this patient has never had lung function tests. And I did mention before that his chest X-ray showed he was perhaps very mildly hyperinflated. So I think doing some in-lab lung function studies to better assess his spirometry, see if he's hyperinflated, see if he's got impaired gas exchange capacity and his lung volumes to look for gas trapping would also help us understand if he has a respiratory contributor to his breathlessness. And then the next question is, what imaging are we going to do? This patient has a lot of comorbidities. Dean, maybe you can talk through how you'd approach this, an HRCT versus a CTPA versus even a low-dose scan, to try better figure out what this patient with chronic lung disease has. I think probably pulmonary emboli is less likely. Dean, what do you think?
Thanks, Paul. Yeah, in this situation, you've already mentioned the patient had a previous chest X-ray. So that's good because we don't need to do that again. We already know that the patient is hyperinflated. In this situation, I think it's reasonable to go on and perform an HRCT chest protocol. Remember that this is a dynamic CT chest. So it's going to include the inspiratory, the expiratory, looking for air trapping, which may be a contributor to his symptoms. And it's looking at prone versus supine. And the main reason for that is to look if there's any structural abnormality. So if there is any evidence of interstitial lung disease, if there's any evidence of asthma, bronchiectasis, any diffuse lung disease, other diffuse lung disease like cystic lung disease, that would all be identified on an HRCT chest. In addition, while doing the HRCT chest, we can do a CT LVAS, which I've mentioned before, requires only the same protocol as HRCT in order to be able to do that post-processing. And that may identify some changes in the lung that are beyond the structural changes. So specifically with respect to ventilation defects and heterogeneity in the lung. So on screen, I have an example of this. This is an example that fits your case of a patient who has what appears to be central lobular emphysema. It's moderate. They also have some cardiac changes, which is consistent with what you've said. And then when you look at their CT LVAS, we can see that there's quite a heterogeneous color map, and that corresponds to two things. Both the fact that they have the emphysema, but also the fact that there is probably some underlying ventilation issue as well. So this information will help with the stratification and I guess the decision making about whether or not this patient is going to go down the respiratory or down the cardiology pathway.
So now we've done the imaging, and I'm not going to talk through what the imaging was for this man because there's just too many things to go through. He's got so many comorbidities. But with this patient, I'd probably be referring to both respiratory and cardiology because there are contributions of both to his breathlessness. And if he's walking up just a flight of stairs and he has to stop to catch his breath, both of them really need to be optimized to the best of their ability to help reduce the burden of his symptoms. And so when I'm framing, so he'll need to be referred to both. Or if you live in a city where there might be a general physician, that might be another way to get around it, but he probably needs proper cardiac and respiratory assessments. And then how I'd be framing it to the patient, I usually tell people that there are multiple reasons why you're breathless, and each of them are additive, and we need to try work on treating all of them at once to try reduce your level of breathlessness. And so while we're waiting for the respiratory physician and the cardiologist, here are the things that we can try do to help with your breathlessness. And some of them might be about losing weight, addressing his comorbidities. If he has risk factors for it, obstructive sleep apnea can be a cause of breathlessness through the day. And he's certainly got enough risk factors for obstructive sleep apnea. Most GPs can order a sleep study if the patients meet enough of the criteria. You might address their anemia, and you might consider rehabilitation, whether that's pulmonary rehabilitation, cardiac rehabilitation, or just exercise conditioning, depending on what the patient's diagnoses are. Muscle training will help that patient to feel less breathless. And so it will depend somewhat on the lung function studies, whether you can refer to pulmonary rehabilitation, because someone with normal lung function, you can't really get them into pulmonary rehabilitation, but you can get them into exercise training. And this patient was, I think, in his 70s, and there are a lot of older age exercise classes around which can help with both falls prevention but also reconditioning that should be able to help. So the key teaching points from that study in that patient is that chronic breathlessness often reflects multiple inputs from many systems, and typically not just one single disease. And our aim is to optimize each to improve a patient's symptoms, because their breathlessness at the end of the day is their symptom, and we want to try relieve them of that burden. And I think one of the worst things that you can say to patients, we'll talk about this more in the second webinar, is, oh, your lungs are fine, or the cardiologist says your heart is fine, there's nothing more we can do. And that's so depressing for patients to hear. And so you always want to say, look, there's something we can work on, whether it's the weight or sleep apnea or their exercise. They're always things that can be worked on to try and improve things. And at least it gives them some hope that things might be better in the future. So look, that concludes the first webinar. Thank you very much. And I hope you enjoyed it.